Well, a warm welcome to today's talk. It's Thursday, the 3rd of March. Now, since the start of this pandemic, we've been talking to doctors and nurses who've noticed that their poorlier patients and the patients that go on to intensive care, for example, are often low in vitamin D. This has been somewhat anecdotal till now, but we have some pretty firm evidence of this now from Israel. So this study is showing that people with low vitamin D levels are more likely to catch COVID in the first place and more likely to present with severe illness and indeed more likely to die. A remarkably important study. It's quantified what we've suspected for a long period of time. Now it's all there. This plus one is actually a peer-reviewed site. It's open access, so you can get the whole paper. And the paper is, about half of it is quite accessible. About half of it you need to know a bit of statistics to make sense of it. But anyway, let's dive straight in. Not to this first of all, but to the background. Now the background is vitamin D deficiency and prevalence and cardiovascular risk factors in Israel, because this study here is recorded in Israel. And in the Middle East, we generally find there is low levels of vitamin D. Now, of course, this is one of the sunniest areas in the world, and yet a lot of people have low levels of vitamin D, surprisingly, because they don't actually get that much sun exposure. So this study here was looking at the prevalence of vitamin D deficiency with, in this example, cardiovascular disease of the heart and blood vessels. A large study, 34,000 people. Men and women, the average level of vitamin D in women was only 22.7 nanograms per mil, and in men it was 23.2 nanograms per mil, so both pretty low. Prevalence of vitamin D deficiency or insufficiency. Now, vitamin D levels that were lower than 30 nanograms per mil. Now, we could argue where we put this number, but that's where they put it. But 77% of women and 79% of men were deficient, or we could certainly say below the optimum level. We can certainly say that, even if we don't go as far as claiming this is deficiency. So it's very common. It's very common, over 3/4. There was only a little variation when stratified by age, so younger people and older people were both deficient. Although generally, in most studies, we do find that older people have higher levels of deficiency because they're spending more time indoors. Prevalence of deficiency in Israel seems similar to less sunny regions. Strange, but actually true. This is what they found. Now, they did take two groups in this study. Group with vitamin D levels of less than 15 nanograms per mil, and a group with vitamin D levels of greater than 30. So they had two groups here. One group is definitely low, this less than 15 nanograms per mil, and the other group here more than 30, so there's kind of clear blue water between the two groups, so they could do a comparison between the two groups. And they found this was significant. So anything less than p equals 0.05 is significant. So this was significant. Age-adjusted odds ratio for the presence of, and they found people with lower vitamin D had more high blood pressure, more diabetes, more dyslipidemia, abnormal fats in the blood, more obesity and more peripheral vascular disease. Not to say they're causal, but these were correlations that were discovered. But there are other studies we could look at that does show there's at least some causal component, or we could argue strongly there's some causal component. But the reason I showed you that was this shows in Israel and the Middle East that vitamin D deficiency is common. So if it's common there, what's it like where I am in another? Maybe I can give you a quick glance out my window where it's another typical north of England day. There you go. It's pretty overcast, cloudy, no sunshine. The chances of making any vitamin D outside today in Carlisle, where I live, are essentially zero. You won't make any at all. The combination of the time of year and being overcast, not good. Anyway, let's go on to look at this particular study, which was COVID related, having established that vitamin D deficiency is of a high prevalence. So this is the study here, as we've said. That's it. Pre-infection, 25 hydroxyvitamin D levels, and association with severity of COVID-19 illness. So for a while we've known that potential correlation, low vitamin D, and increased risk of infection and poorer clinical outcomes. So the lower the vitamin D levels, the higher the risk of a bad clinical outcome. And this study examines any relationship that exists between pre-infection 25 hydroxyvitamin D levels with disease severity. So they had a scale here with people on this scale here. This is what you call a multivariate analysis. The statistic can take into account lots of different levels, and the statistic can take into account lots of different outcomes, which of course is very clever, but it's all done on computer programs these days. So they're able to correlate these two. Pre-infection. Now, why were they looking at pre-infection? What wouldn't make a lot more sense when you're doing this study to just take everyone's vitamin D levels when they're in hospital, then we get an up-to-date assessment? Well, the problem is that acute inflammatory conditions will use up vitamin D in the body, and vitamin D levels will be lower. So if you take someone who comes in with reasonably adequate vitamin D levels, when they're very ill, the vitamin D will be used up and the vitamin D levels will go down. And then you'll get people arguing about cause and effect. So you get sicker people with lower vitamin D levels, but some people will say, yeah, they had lower vitamin D levels, but that's because they were sick. The low vitamin D levels were caused by the illness, where in actual fact this study is demonstrating that it was the low vitamin D levels that increased the severity out of the illness. It's the other way round. So they had to take levels before people became ill. Quite a clever, sophisticated study this. Do stick with it. It's really quite interesting. So they took data from the 7th of April to February the 21st. So that takes us all through the Wuhan strain, doesn't it? And it takes us through the Alpha strain, of which they had plenty in Israel. And PCR tests were used to confirm, of course. And then they searched for historical vitamin D levels 14 to 730 days prior to the infection. So this eliminates the argument that people have been making. When I did my vitamin D debate with Tim Spector, he actually suggested this as a possibility, that it's the illness that's lowering the vitamin D levels, but this is showing that it's the vitamin D levels that are causing the illness or predisposing to the illness. Now, the design, patients were categorised by disease severity, so disease severity and levels of vitamin D. Deficiency was taken as less than 20 nanograms per mil. There was 133 in that group. Insufficiency from 20 to 30 nanograms of vitamin D per mil of blood. There was 36 in that group. Adequate was taken as 30 to 40 nanograms per mil of vitamin D. There was 30 in that group. And high normal was taken as 40 nanograms or more of vitamin D in the blood, and there were 40 in that group. And they did something very clever here. Now, I read this statistic and understood it at the time, but I couldn't quite explain it to you now. But they accounted for the fact that there's a sinusoidal wave for vitamin D, so it goes up in summer, down in winter, up in summer, down in winter, and they're able to account for that using really quite, well, it looked like sophisticated statistics to me. I'm sure it's bread and butter to statisticians, but they accounted for that. Now, this hospital group, 1,176 patients admitted, and they got information on 253 who had prior recorded levels of vitamin D. So they had quite a good number. A lower vitamin D status was more common in patients with severe and critical disease. That's a simple statement from the authors. So we can say in this study this is true. Now, this doesn't prove causality, but it's pretty... To tell you the truth, the reason I'm doing this study is I'm just completely convinced by it. It is very convincing data. In patients with severe critical disease, 87.4% of patients had less than 20 nanograms per mil of vitamin D in the blood. In patients with mild or moderate disease, it was 34.3 had less than 20 nanograms. So we see that number is much higher than that number. And when you take the difference between these two numbers into account, you end up finding out the difference between those two numbers and the number of patients with these different numbers. The probability of that arising by chance is 1 in 1,000, p equals 0.001 or less than that. So this is a definite, significant difference. There were more patients with severe and critical disease. More people with low vitamin D, 87.4, severe and critical disease. A significant difference between the groups. Clear blue water between those two groups. Now, patients with vitamin D deficiency, less than 20 nanograms per mil. 14 times more likely to have severe or critical illness. Odds ratio of 14. 95% confident intervals. So compared to those with higher vitamin D levels, the highest vitamin D levels, they're 14 times more likely to have severe or critical illness. So patients with the lowest vitamin D levels, incredible, 14 times more likely to have severe illness. The odds ratio was worked out at 14, as we said, and they're 95% sure that that number of 14 was between 14 and 51. So it could 4 and 51, sorry. So it could have been as low as 4. That's mathematically possible but unlikely. Could have been as high as 51 times. Again, mathematically possible but unlikely. That's their best estimate, 14 times. So would you like to reduce your risk of severe illness by a factor of 14? If your vitamin D levels are less than 20 nanograms per mil, then this would indicate that it is within the realms of possibility that increasing your vitamin D levels would also decrease that risk. So that shows us what it was. Mortality in patients with sufficient vitamin D levels, 2.3% of those patients died. Of course, these are patients being admitted to hospital anyway, so these were the illest patients anyway. Mortality patients deficient vitamin D levels, 25.6. Wow. So these patients were sufficient vitamin D levels, 2.3% mortality. These patients were deficient, 25.6% mortality. And again, if you take that number and you take that number and you take into account the number of people in the groups and you take into account the difference between those two numbers, again, the probability of that happening by chance is less than 1 in 1,000. It really is quite convincing data. Now, I could go on and give you a lot more data. I'll just show you maybe one more thing just to illustrate that they did a lot of other statistical analysis as well as this. And this just shows here the vitamin D levels here going up. And the disease severity here getting worse as we go along from mild, moderate, severe and critical. And we notice, although there's error bars and everything, we notice that there is a negative correlation here. So that trend is like that, isn't it? So there's a definite trend for people with lower vitamin D levels to have more critical illness. It's really quite clear. So what did the authors conclude from this study? Among hospitalised COVID-19 patients, pre-infection deficiency of vitamin D was associated with increased disease severity and mortality. It's a pretty clear finding, really. A low vitamin D status has been associated with a range of autoimmune, vascular and infectious diseases. Now, this is actually the end of the talk here. So the conclusion is, amongst hospitalised patients with COVID-19, pre-infection deficiency of vitamin D was associated with increased disease severity and mortality. Now, it's outside the realm of this study, but there are many studies show that if you increase your vitamin D levels, it has a very protective effect. So that's basically the end of this study, but there's some more information here for those that want it. So low vitamin D status has been associated with a range of autoimmune, cardiovascular and infectious diseases, as we've looked at and seen evidence for. Now, this is because vitamin D is an essential immunological moderator, and it affects pro-inflammatory cytokines. So the cytokines are chemicals produced by one set of cells, particularly the white blood cells, in fact, in this case, that cause, and if there's too much of these, of course, we'll get a cytokine storm. So it has an inhibitory effect on tissue necrosis factor alpha, which is a pro-inflammatory mediator, and interleukin 6, which is a pro-inflammatory mediator. So adequate levels of vitamin D are both increasing the quality of the immune system, but also reducing the likelihood of a cytokine storm and an excess inflammatory effect, which of course is exactly what we want in COVID-19 and indeed in anything. We want the immune system to be working absolutely tip-top, but we don't want it to go nuts and produce masses of cytokines that kill the patient, as occurs in sepsis. So epidemiological risk factors for vitamin D deficiency, as we know, darker skin, low sun exposure, skin covering clothes, especially in women in the Middle East. This is a big factor in women in the Middle East. Sun creams that block out the UVB, ultraviolet B radiation. And diets to some extent, although by far most of the vitamin D we have comes from the sun. This is the sunshine vitamin. An association between low vitamin D levels in the blood and increased risk of acquiring influenza and respiratory viruses. has been established. I'm not going to give you all the information for this now. We have established that, or given very, very strong evidence for that in previous videos. Meta-analysis of randomized controlled trials 2007 to 2020 shows that if you increase your vitamin D levels, you induce your risk. So this study, of course, is a correlation, but many other studies show that if you do increase your levels of vitamin D, you're going to reduce your overall risk, which of course is exactly what we want. So we can actually intervene here. Vitamin D supplementation reduces the risk of acute respiratory infections compared to placebos. So vitamin D supplements, according to this data, work. Factors associated with poor prognosis: geographical location in northern countries. We've done particularly badly compared to Africa. And of course, Africa's a sunnier country. People spend more time typically working outdoors. Older age, because older people spend more time inside. Their vitamin D levels are low. Black and ethnic minority groups have suffered disproportionately, in Europe at least, and indeed in the United States also. Obesity, pre-existing conditions, diabetes and hypertension. And we actually showed there's a link between diabetes and hypertension in the previous study. Well, hypertension anyway, not so much diabetes. The risk factors also independently associated with vitamin D deficiency. So these things are also independently associated with the vitamin D deficiency. So why not get rid of that variable? If it's safe to do so, why don't we get rid of that variable? Why aren't governments talking about this? Why isn't the chief medical officer and the chief scientific officer standing up and saying, you should optimise your vitamin D levels? Why is this not being done? Vitamin D is cheap. It's readily available. Here's my supply from the supermarket. And I'm also taking some vitamin K2 with mine as well, because the vitamin K2, so the vitamin D can release some calcium into the blood. Now, if you take normal doses of vitamin D, you're not going to get a very high blood calcium. You're not going to get what we call an acute hypercalcemia, unless one in many, many thousands of people do who are genetically prone to do that, but most of us don't. But if you're taking vitamin D, it does liberate some calcium, increasing calcium metabolism. And the vitamin K2 makes sure that released calcium goes into the bones and not into the tissues. Now, you might say, well, surely if you're getting a normal diet, you're not going to be short of vitamins if you've got a good, healthy diet. And normally that's true. But remember, most of the vitamin D comes from the sun, and we don't get it. You're very, unless you're an Inuit, you're very unlikely to have a diet which is adequate in vitamin D. And even then, only if you're an Inuit with traditional lifestyle. So it's the lack of sun that means we need that. And the K2 is unusual vitamin in that the vitamin K2 is made by bacterial fermentation. This is made during fermentation reactions. And fermentation is basically breaking things down in the absence of oxygen. A chemist can correct me on that, but that's basically what it is, breaking things down in the absence of oxygen. And this happens inside animal guts, for example. So the grass that the animal's eaten has been broken down somewhat anaerobically, and vitamin K2 will be produced. And that vitamin K2 from the animal will go into the animal tissue. So if we then eat that animal, we'll get vitamin K2. Or if we drink the milk from that animal, or if we eat the butter made from the milk from the animal, we'll get vitamin K2. But of course, a lot of the cattle we eat now, or the animals we eat generally, well, many people are vegetarian and vegan, of course, but a lot of the animal products we have now are produced using what I consider to be unethical farming practices, and they're fed with grains and soybeans, not grass. And it's the grass, the fermentation of the grass particularly, that leads to the formation of the vitamin K2. So grass-fed animals likely to be a good source of vitamin K2, otherwise not. And the other source of vitamin K2 is from fermented foods. So this one's actually made from fermented natto beans, which are soya beans. And natto is eaten commonly in Japan. And when I worked with Koreans, they ate kimchi with every meal, including breakfast. Literally, they'd have a bowl of kimchi on the table with breakfast and crunch away on it with every meal. In the UK, we basically don't eat fermented foods. Therefore, we don't get vitamin K2. So it makes perfect sense that, you know, if we're out in the savannah, when we were hunter-gatherers, we get lots of vitamin D from the sun, and we get K2 from storing foods, thereby allowing them to ferment, and from animals that were grass-fed, whereas now we don't get these vitamins. So that's That's why those vitamin supplements are needed, vitamin D and vitamin K2. If you live in Japan, you work outside, you're eating seaweed, you're eating natto for breakfast, then you're going to get your vitamin D from the sun because you're working outside, and you're going to get your vitamin K2 from your fermented soybeans, from your natto. But I tend to work indoors, and English culture doesn't eat a lot of fermented foods. In fact, where I live, you can't even get it. If you go around looking for fermented foods, you can find some sauerkraut in the supermarkets, but that's pasteurised, so it's not as good. Anyway, difficult to ascertain definitive whether it's causal or not. So what this is saying is this study is good because it's measuring vitamin D levels before people had infection. Therefore, non-believers in the efficacy of vitamin D at preventing severe illness and death are not able to argue by saying, well, it's not that the fact that they had low vitamin D when they came in, they acquired low vitamin D as a result of the illness. That takes away that argument, which is excellent. And this was the model they used to level out the year, a consigner model. I'm not going to try and explain it because I don't really understand it, but it's quite impressive. And also in Israel, they found Israeli Arabs had much lower levels of vitamin D. Well, there was 64.3% had 20 nanograms a mil or less, compared to 35.7% of non-Israeli Arabs. So interesting. We could spend. The paper does look at reasons why this difference might be. It's largely behavioural, partly genetic, but it just shows that what happened in Northern Europe was, or at least in my country was, there seems to be so much desire for virtue signalling and all this kind of thing that the Guardian newspaper and the other people, as soon as there was this difference noticed between ethnic minorities and their death rate from COVID-19 and other groupings and their death rate in severe illness from COVID-19, said, oh, must be deprivation. These poor people in ethnic minority groups are obviously poorer, they're socially ostracised. But the fact is that the first group of people that tragically died of COVID-19 during the pandemic from ethnic groupings were mostly nurses and doctors. And I don't really think you can say that they are particularly deprived, especially the doctors, who are generally pretty well paid. So I find it very concerning how many thousands of people have died because people were so keen to talk about sociological differences, which you could argue don't exist anyway. I don't particularly see any differences in ethnic minorities where I live and work, in terms of income or in terms of housing. People were so keen to jump on that bandwagon that they missed the obvious biological difference that darker skin produces vitamin D more slowly. It is that simple. And here's the graphic that Liz drew for us way back. If it's going to work. Is it going to work? There it is. Yeah. Darker skin protects from sunburn, but produces vitamin D more slowly. So there you go. Lighter skin burns easily in the sun, produces vitamin D quickly. And yet still this difference is not openly discussed, at least in the UK. And as a result of this, I'm convinced many people have died, which is a pity. No, it's not a pity, it's an absolute tragedy. So why on earth aren't we talking about this? Why isn't the government changing its guidelines? Is it the fact that you can buy a nice big tub of high-strength vitamin D tablets from the supermarket for £3? No, I'm sure it's nothing to do with that. There you go. Thank you for watching.